That worked. So my name is Dr. Raul Vasquez, and I was asked to basically talk a little bit of what I do. Huh?
Put the mic a little bit further from.
Oh, now it's too loud? Okay.
Can't please anybody around here.
I'll be better. So I'll tell you a little story as to why I do what I do, but I grew up in the inner city, and I grew up in the Bronx. So as a Latino young man growing up, I grew up in the projects, and I grew up on Medicaid. So it was different for me to kind of see that life. And so I always saw how my Uncle Joe would go to the hospital and couldn't interpret. He couldn't speak English that well. So I was an interpreter back then, and I wanted to have an impact in these communities a little bit different. So I ended up in medical school, and I ended up here in Buffalo. Buffalo by accident. I had a good friend that came here, and I came in for an interview, and I found myself really like, this is a really nice, it's different. It's not like the Bronx, where really a lot of traffic, a lot of people. Here it seemed a little bit different. I wasn't exposed to that. Ended up coming here to medical school. An interesting thing happened. The first week of medical school for me was very difficult because I just had a different pattern, and I was asked to come into the Office of Financial Aid. And Dr. Ricker at the time basically passed me an envelope. So, here I am. I'm the first to go to high school, graduate from high school, the first one to go to college, first one to now go to medical school. And my mom, whether I did what I did, she was proud of me no matter what. So I get an envelope passed to me, so I thought, okay, well, I'm going to have to do something else in life. But it was actually a check. It was a check for $37,000.
Oh,
I was the poorest student to ever go to UB Medical School. So I was, I cried a little bit, and I told him it's okay. I'm not offended. I'll take the envelope. But through all my career, there, I decided to go into primary care. And while I was doing primary care, what kept me here was my lovely wife, Tony. Because I met her, we met on Main Street during residency when I was about to graduate. And, her vision, meeting her parents, and knowing that they had really been in Buffalo for a longer time, things happened. So we stayed here. In 1996, I decided to open up a practice, but I wanted to do something different. So I opened it up in the inner city. And now there was no private practices in the inner city. Today, 25 years later, I am the oldest practice on the Lower West Side. And during the time, what I wanted to do was really provide a different level of care for that community. And I think that's been what our dream has been. In 2003, we knocked Precinct 10 out on the west side, and we built a medical facility. And during that time there, we were able to really do a lot of good things for the community and really change healthcare, largely along the black and brown populations. We found that those areas, we neglect them. I mean, some areas, when COVID comes out, like it did, we see what's already been there. So there's more of a focus on it, but it's always been there. Along my career, in 2013, we were able to get involved with health funds. They were a new product, and they were talking about, health disparities and health equities. So, people talk about that, but I lived it, And in 1996, I had my Uncle Joe, who lived in Buffalo, and he was my driver. He would pick people up, bring them in. When people didn't have food, we saw them. When things were going on, we just did things. Because it's the humane thing to do. It's not anything special, but we decided to do that. We ended up kind of growing as a health home, and we ended up with 220 employees now in 2021. And I think we metamorphed into something completely different. We also went into contracts and really trying to get into the healthcare insurance business because we found that the dollars often get misused and patients don't get access to the service they believe they need. And certain markets just get totally cut out. So with all this stuff, what we've been able to do is really transform healthcare. And I think I learned a very important lesson during my time, that what changes the communities, I would sit there and talk to my father-in-law. And I answered, is this, is it that? What's going to change our communities? Is it that, is that? I gave him about 26 answers. And he said, no, it's three things. Very simple, Raul. And I said, what are they? And it's jobs, jobs, jobs. And so when we did that, we were taking individuals that were on Medicaid, got them trained, and now they work sustainable jobs. They're my best workers to try to get people to improve their health care. During this pandemic, we managed 18,000 lives. We were able to, we only lost 5 individuals to COVID. 5 is too many, but we were there for all that community. My employees, we didn't lose any of my employees. But we were able to touch a lot of people's lives, and I think everyone was scared. And I think we did a really good job when the vaccines were needed. We jumped into the game. We partnered with community health centers, we partnered with churches, and we were able to vaccinate. We were the first practice in all of New York State to vaccinate, and we vaccinated over 12,000 people. I think the key thing is to really try to do something different. But the biggest problem we have is the lack of primary care. Most doctors don't want to do what I do. Our hospital systems train people in sick care. So if you're a cardiologist, a radiologist, any ologist, but primary care, most students are coming out with big deaths. That's what they're going to do. And I think we have to really try to change the model for that. And I think what me and my wife have done is really done that. I think now, you get to the point where, what's our next stage in life? And there is another stage. So I meet another gentleman that was a Brooklyn kid that grew up in the projects. And so together, what we're trying to do is really expand what we've done here in Buffalo, in Brooklyn, in the Bronx, and in other states that have similar issues because the needs are there. And that's where our next sort of stage in our lives are right now. But I think what was it? Nice. Oh yeah, so the point here is that, we didn't start out doing this, and now I'm pretty religious in terms of God has always guided me to these places. And he's always put me where I needed to go. When we were looking to build back in 2003, he guided me to build the new facility. My wife was his angel pushing me along. And I think, we have 4 kids. And the funny thing is that in 1996, when I was opening the first day of my private practice, my wife was in labor. And so I had to run from seeing patients to the labor room. And I said, babe, you gotta hurry up. I still got 10 more patients. So I would go back and forth, but you know what? I made it for that delivery. And I think the amazing thing is that young lady I delivered, that was my wife delivered in 1996, is a 3rd-year medical student at UB today. All right. Going into primary care. All right. We have an older daughter that is in her 2nd year at UB Medical School. So we've been pretty blessed. The funny thing in this whole story, and I don't want to keep you too long because I can bore people to death, and when you give me a mic, it's the wrong thing to do, is, okay, I'm sorry. So I got a few minutes. But the funny thing was, so when my first daughter, Nina, which is my baby, she got into medical school. We were arriving to JFK on the plane. And when we landed, she said, "No, Dad, I got into UB Medical School." I said, "Oh my God, that's wonderful." But my wife started to cry. And I was like, I couldn't understand what it was. But for Tony and her family, she was the first person to ever be a doctor. And both lines of her parents. No one had ever been a doctor within her family. And then Nadia, following up, so it's 2 for 2. So I think, it's transformational. I think it's important. These communities need people that look like them too. It's really important because you got to see it to be it, and I'm always pushing people. And we've touched a lot of people. We have touched so many people that sometimes you don't know the impact you have. And as life has gone on, these individuals come up. I'll tell you about one individual, and then I'll cut it short. So in 2003, I'm building the building. They're putting a fence around. I'm talking to this gentleman. He's doing his fence. And he asked me a certain questions, and I was just answering the questions. I go up to J.C. Seneca when we were vaccinating the Native Americans, and we're doing a great job up there. This gentleman comes up, he's Native American, and he says, "I want to tell you something, because you don't remember me." And I said, you look familiar. He says, I was that gentleman that was putting the fence around your building. And when I saw the things that you do for your people, I went back to school. I got a master's, I got a PhD, and now I'm doing addiction and substance abuse within my community. So that's how you change people's lives. And so I want to thank you guys for really having me here, and I'm honored, and I didn't know if my wife wanted to say anything.
Oh, yeah, we'd like to hear from her.
Don't be shy.
Come on. So you're going to be doctor.
I just wanted to ask a question. So what, you have several different locations, you said, and they're all on the west side or?
Yeah, so we have a couple of different, and we're going to be expanding more. We have the 564 Niagara Street, and there we have Urban Value Practice, G-Bond, Jabaco. These are all the separate companies. We have 1195 on Main Street, where we're also located, and we're doing a lot of care coordination. But we're also on 1315 and 1317 Jefferson Avenue. So we're really focusing there. We're looking to build the same facility that we have in 565 Niagara Street, which is a 40,000 square foot building, which was about $7 million, the largest project that ever was put in there by a doctor or private entity on the Lower West Side, because we wanted to give something back. We're going to do the same thing on the East Side.
So, can you say a little bit about universal health care and how it would affect all your vision plan?
So the question is universal health care. How would that change what I do? So what we're doing is very important. In terms of, when I said we got into the insurance company, is we started going after value-based care. And that's when you budget and you can manage people. We want to go back to people's homes to manage people. We don't want to wait till people get sick in the hospital. That's how we want to do it. We want to do a lot of things that can really change people's care. So not worry about the fee-for-service. You got to get all these people through the system. We want to manage people and create value, looking to get people well, to get people the medicines they need. And that is a lot simpler because 10% of the population costs 90%. It's all going to hospitals. It's all going to centers that don't need to be. But we have to go back to the Marcus Welby's, because that's what I used to watch when I was a little kid. And that was powerful. Because you know what? You didn't sometimes have to do anything. You just have to sit there and talk to people. And we have often forgot that. So yes, yes, and yes.
Marion
I'm
has a
sorry.
question.
Could you tell us a bit about the population that you serve? What are some of their unique characteristics or unique problems that you might not know about?
Yes, so I serve a couple of populations. So the Latino market, the biggest thing that we have, and the African American market, very similar because we're exposed to the same things. And food, if it tastes too good, it's going to kill you. So diabetes, affecting both markets. And I think the sad thing about diabetes is we don't manage it well. And because we don't manage it well, we have a lot of complications. And it's good for hospital structures because you generate revenue. But that's not what we're here to do. The sad part is when you have an amputation in a diabetic, he probably only has a couple of more years to live. And he's going to cost the system a lot of money. But if we were doing the right things early and intervening with diet, exercise, getting the medicines right, we would have done a great job. So diabetes is huge. My uncle, asthma. On the Lower West Side, we got a lot of older homes, we have bridges, we have a lot of that stuff that takes place. So asthma is really a big problem. I've been managing asthma for a long time. For the last 20 years, I admit less than 0.5% of my asthmatics. Because it's important to me. We have to be more aggressive, we have to go after eliminating smoking. Okay, we have to go after, sometimes the animals, you have to be careful. Cats, dogs, some of these individuals get sick with that. Allergies of all kinds can be a problem. So just addressing those things, asthma, and the biggest thing of all is hypertension. I mean, unfortunately, we do a health fair every year, right? And this past year we did. We have about 2,000 people that come out. Really? And we just screen everybody, yeah. We give away t-shirts, we give away computers, we give away bikes. We've done that, I've been doing that year after year after year. And I think what I found was that you look at the data, and people walking around with blood pressures, whether you're Latino or African Americans, blood pressures are 240 over 140. But they don't have hypertension. Okay, so it's just the guidance, make sure that we do that. So diabetes, hypertension, and asthma are the biggest things that we run into. And unfortunately, when you don't, if you look at the dialysis units that we have at these hospitals, and dialysis is good, it's good for business. It's $75,000 a year I'm gonna make on those individuals, okay? But we should work on not having so many, and a lot of black and browns in that population. If we transplant more of these individuals, it costs a little bit more money up front, but the quality of life and everything else that we do is the right thing that we need to do. We still don't do that. We just want to build more emergency rooms. I'll finish on this. The 14215 suffered the most. Okay? It suffered the most with COVID, lack of vaccinations, deserts. I mean, I can go on and on. The sad thing is there's 2 hospital systems in the 14215. So, and they get extremely funded. Okay? And they're building more emergency rooms. So what I'm saying here is we have to, and they also get subsidized by Erie County quite a bit. They get what's called IDT money, $70 million a year that ECMC gets to go back and build primary care networks and help. And none of that money impacts any of the outcomes. The outcomes for the 14215 have not changed 1% in the last 35 years that I've been here. So if we're going to have an impact, that's how we have an impact. But it has to be attached to outcomes, very important outcomes.
So how have you been able to afford to do all this? Do you get Medicaid from people? A lot of people don't have Medicaid, right? So tell me how you have managed to do it.
So I'm a legalized drug dealer. What it means to me is I've managed to, not only in the primary care, is really focus on contracts. So when you're managing a full contract, like last year, in 2020, because I brought in all these other doctors and we took on a population and we managed them, we kept them out of the hospitals, kept them out of the ER, we generated $6.4 million in savings. Those dollars come back and they get shared among the doctors that did the good work. GBON, which is my organization, care coordination, where we have 90 people that manage 7,000 lives. For the last 8 years, we have cut ER utilization by 64%, and it's been maintained for the last 8 years. Inpatient care by 84% for the last 8 years. The savings of that alone is sufficient to kind of let us do the things that we want to do.
So do you get the money from the government?
No, we're in risk contracts. So what ends up happening...
What's a no-risk contract?
So a risk contract, very good question. So a risk contract is, I deal with Fidelis, right? I've got 21,000 lives. I take on full risk for that population. That means I am managing. So if there's a medical loss ratio, right? This is what it is. If you're managing people, getting people the right meds, keeping them out of the hospital, doing all the things, getting their diabetics managed, getting all these things, getting all this stuff managed, you save money, and as a result of that, those dollars come back to you.
Great.
And there's also now, there's a push for social determinants of health, so you get dollars there that you can actually use for food and other products. But that's how you do it. It's not generating more money, it's just using it wisely.
How do you address mental health issues?
So, mental health, nail on the head. I've been a psychiatrist for 35 years, even though I went into primary care, because people come in, depression, bipolar, schizophrenia. The problem we had, because back in the Columbus day, I was treating patients at the hospital, and the schizophrenics, we would give them iron shots of antipsychotics, medications once a month. It stabilized people. So behavioral became something that I had to do. No one wants to manage behavioral in the inner city because it's Medicaid, unless you go to a clinic. And that becomes a problem because there's no attachment to a provider. So you're stabilized on a medication that your provider sees. You show up at ECMC, they change your meds. now you start, hearing voices and going back to the thing. So, because there's no connection. So behavioral and primary care are crucial. And how we save money is by connecting these two. Because you get people stabilized. You have someone that has schizophrenic, you give them an iron shot once a month, you make sure they get it, you incentivize them to do it, they're stable, no problem. No jail time, everything's perfect. The biggest thing we also have is substance abuse, right? We have a lot of people that take opiates. And the opiates they're taking because they have mental illness. They're bipolar. If you take opiates, it stabilizes, the mood stabilizer. So we find ways to treat these individuals with Suboxone, but IM shots of it, not pills. Because they'll substitute one for the other. And now you can take someone that was not doing very well, you get them back, they transform in front of your eyes, and they go back to work. So there's a lot of things that we can do that'll save money instead of feeding a system. So I'm not a big, in the next 5 years, you guarantee most hospitals that you know today will not going to be around. It's going to be transformational. Just like Amazon did to retail, the same thing is going to happen in healthcare. So we have to be very, very careful in terms of how these things continue to be built out, because you're going to have empty buildings.
Can you consider going before Congress and saying that? Because I've been saying the same thing for 20 years.
Absolutely. If you're going in front of Congress, well, I tell you what, I send, for something like that, I send my better half, because I think she could be a good congressman in the future. Tony Vasquez. Congresswoman.
There you go.
See, I got myself in trouble. It was him, I was hanging around too much.
But Congress isn't going to do anything because it would be against the sugar interests. It would be against the salt interests and the food interests. And they have to keep the people sick in order to keep the pharmaceuticals alive and in order to keep the
Our
hospitals
Congress
alive.
people should be pandering to those people, and we need to vote those people out.
And the only way you're going to do that is to have a voting bloc that's so strong, because right now the rich people rule, whether you like it or not.
But it has to change, because by 2040, the actual, so the Medicare fund is drying out by 2040. So it's going to go on the gross national, you're going to have to deal and address with this, because we spend $2 billion a day in Medicare costs, all of it being eaten up by hospitals. So if we don't, and I don't want to spend my last days in the hospital. I want to have a way to kind of just leave, when I leave, in a graceful way. And I think that's the model that until you've been there, you don't understand. And I've had a lot of deaths in the last couple of months. So it's I saw my uncle in Puerto Rico about 2 weeks ago. In Puerto Rico, died in his home and had everything he needed around him. And that in Puerto Rico, in the mountains. So if we can do that there, we can definitely do that here in Buffalo and anywhere part of New York State.
How do you say the hospitals are going to change? I'm just curious.
They're going to have to, right now what's happening, so guys like me are going to manage the money. And so it's physician driven. So what I'm saying to you is that I don't want, like, if you have an upper endoscopy test or a colonoscopy and an ambulatory surgery, it's $2,000. If I do it in the hospital, it's $21,000 for the same procedure. So how do you think? If I shift it over there and the doctors get incentivized for doing this and it's a better service and the patients are happy, you're not going to have a lot of space you're going to have big buildings that you're not going to be able to afford.
Except right now with the pandemic, we're hearing that there aren't enough hospital beds, so we're almost out of them.
Yeah, so because this system has been designed the wrong way. So if you don't have COVID when you go in, you're going to have COVID by the time you leave. My stepmom died 3 weeks ago because she went into the hospital COVID negative for an elective procedure, and 8 days later died of COVID. So yeah, that's the problem. So they're generating a lot of, unfortunately, COVID. You had a question?
Well, I'll get it out. It seems, though, that in a way, it's almost paradoxical, because a lot of that outpatient stuff is happening. Full disclosure, I'm a retired physician. So it's hospital, and my husband also, and he's been in the United States now for 50 years in Buffalo, and since then, 25 area hospitals have closed. A lot of that has to do, I think, with public health, with vaccinations, but also with the very thing you were talking about, which is a lot of things are being done outpatient. Or someone goes in to have a baby, they don't stay there for 4 days anymore, they're out the next day. Or you go in for a hip replacement and you stay at a hotel. So there's that. So because of that, there are fewer hospitals, and now you have this crisis of COVID. So there are fewer places to put them, A. But B, there are all these people who have quit medicine because they feel overwhelmed. So this isn't a question, I guess it was more of a statement. I'm just wondering how you see the solution for this conundrum. On the one hand, we don't want a lot of hospitals. They're terrible places to be. They're people, like you were saying, your stepmom, goes in for an elective procedure and never comes out. On the other hand, you need enough to supply a pandemic. So what are your thoughts about how to work this?
Yeah, I hope everyone listened to the question, but I'll give you an answer to it. We've been building vertical integrated models. And so they're used to managing smaller populations. If you're going to have something at the scale that we're talking about, there has to be a horizontal integrated model, which is care at home. We can do that and more effectively manage individuals at home. And that's about it. I mean, we do it in other countries. It's not just, And so if you're running into issues, the technology, the AI can really help with a lot of the integrations, having nursing, having call systems, just being able to manage. Most of the cases that are there for COVID are cases we can manage at home. We do not need, we found out about COVID early on that we didn't want to intubate all these individuals because there was clots. You were forming clots everywhere. A pulmonary embolism is not something you want to intubate. And so in New York, we killed a lot of people because we didn't know. A lot of people just put them on a ventilator, okay? And that's what happened. And then, then we also had another side where in the Bronx, 3,700 people died because they were scared to go to the hospital. So you've got a black and brown population that mistrusts the hospitals because of the past and things that have happened in the past. So I just think that care at home is where we're going to make our investment. And that's where it's going to really help. And you tier it. So we have, the way we describe it is we have a green house, a yellow house, an orange house, a red house, and a season house for seniors. And I think designing models to really provide services, and if you're managing the contract, which means you're managing the money, you're going to want to make sure that those things are going. So we get the nurses that need to be out there. So if you're sick, instead of having you in the hospital, getting the infusions, doing all this stuff, getting the doctor to visit, if you have behaviorals, getting the psychiatrist to go out, and really engage people with their diets, food, a whole array of things. But care at home is how you do it. That's how you can manage the masses. Hospitals will never be able to do that. With vaccinations, I think I gave more vaccination as a primary care office than all 3 hospitals put together. It's scary.
Do you use telemedicine in your...
Yes. We were actually one of the first. So in 2017, I negotiated a telehealth contract with YourCare at the time, which is Molina. And we were able to do telehealth and get paid for that. So when this pandemic hit in March, first week of March, and I got some of my people around, I told everybody on that Friday, because my daughter got COVID. My baby, my oldest daughter got COVID. She made it through, but it was an eye-opener for me. I told everybody on that Friday morning, you're going to take all your equipment, and you're going to go home. And then I want you to do the following. And we will be gone for the next 4 to 5 months. We're not coming back. And we were able to manage our population through telehealth, through call systems. The few people that we had for testing, once testing became available, we took our wellness teams, and they were just social determinants teams that were getting food baskets to people. Because we were telling people, stay home. Well, multiple generations, not giving them the information so that the infection wouldn't bounce around. Not telling them what to do. So what do? Where do I get food? Some of these individuals couldn't get food. So we were addressing all those issues. And at one point, when COVID testing became possible, we actually sent our vans. We have 5 vans. So we made COVID vans. And we would go out there and get people tested and make sure we monitor them so they wouldn't get into trouble. But if you manage COVID, 90% of COVID can be managed, okay? Now, if we continue to have unvaccinated people, and these, variants continue to change, we're not gonna be out of this for a while. So my point is, and we may need reboosting and all these other things that take place. So it's just a team, working with teams and having people that are all on one page. But the telehealth component was very valuable, and that helped us really do a lot of different things.
Are most of the people that you deal with vaccinated? Is there resistance?
Yes, so most people vaccinated. So in January 2021, I had a town hall meeting with all my team. I had 220 people that work for me. And I said, this is what's going on. I don't want to mandate it, but if you're going to work for me, if you're not vaccinated, I can't use you.
Thank you.
That was it. And as a result of that, I had about 4 or 5 people quit. But then that weekend, a friend of mine had access to the shots. But I told them, I went through the whole description of the vaccine. I was the first to get it. My wife was second, my 2 daughters third and fourth. So if I'm crazy enough to vaccinate myself and the people I love, you got to understand why. And I don't want you to take this the wrong way, but I also told our team in the black and brown population that when the criteria came out, age and all categories, it was mostly white America. So I told my team, this country has never made a vaccine that would hurt white America. And that made them think. Okay, and that's important because we want to get people vaccinated, but they're so scared about Tuskegee and everything else that I still have trouble with some individuals. And, unfortunately, this Thanksgiving, me and my wife had a disagreement. And we never do, but it had to do over unvaccination. We love people, but if they're not vaccinated, they're putting us at stake. And they're not going to come to my house. And so I didn't want to take that stand. I'm sorry. But anyway, so those are the things that I think is, yeah.
So you feel strongly about a 5-year-old getting vaccinated then?
Yeah, so this is the thing. So I've been vaccinating kids forever, for the last 25 years, if not longer. And so I've seen what side effects and things like that. We have never used the vaccine in kids, okay, that has been tested as much. So we have over 120 million people that have gotten vaccination in this country. And the dosing, because it's a smaller dose, it's 10 micrograms. Myocarditis and things like that, no. So I got a choice, die or a vaccine.
Or long-term effect?
No, because if you're going to have an effect from vaccines, and I've got a doctor back there, when you give a shot, in the 30 days after the shot, if you have a problem, that's when you're going to see the problem. If you don't see it during that time, you're going to be fine. Remember that these vaccines they don't have any pieces of the virus. They're just code that teaches the body how to make these questionable spike proteins that aren't spike proteins to trick the body. So that's it. So yeah, my son, my youngest son, he's 15. We have a 15-year-old. He was first, I wanted him to get his vaccine. He got his vaccine. I feel safe now that he's fully vaccinated. So no. And if I do it with my family, it should be something that...
So my granddaughter just got vaccinated, that's why I'm asking.
Yeah, no, she'll be
5
fine.
years old, yeah.
Yeah, no, that's fine. That's the right thing to do.
Do we clone you and just?
Yeah, I don't think my wife can do it too. So, thank you for having me, okay? And the questions are fabulous.
Thank you so much. That was fascinating. And there's so much to learn and so much to know about what's going on and the truth of it. So to get it right from the source is always really important. So just in closing, I guess, I'm not going to open my computer again. But anyway, I just want to thank you all for coming and wish everybody a really pleasant and safe and healthy holiday. And please keep checking our website at lwvbn.org and your voter for all the exciting things that will be coming in the next year. And Elbert, did you want to say something?
Before we go, of
course, thanks to Dr. and Mrs. Vasquez for coming. Fascinating. And, Terry's going to hold this up, okay. I want to acknowledge the Healthcare Committee who helped put this on, and welcome anybody who would like to join the Healthcare Committee. We have a wonderful time, and especially thanks Terry for providing the check-in, the menu cards, and all of that works so well. And so here at the League of Women Voters, we value participation as citizens. And so to honor all the volunteering that we all do, and thank you and appreciate you, we have a door prize. And so I'm going to put Terry on the spot, if you will, Terry, to think of a number 1 through 40 and tell me what that is. 3, all right? I'm going to look at my list and see who is number 3 on my list. And that will be the recipient of this charming basket back here. That person is Arlene Miles.
Oh.
Yeah, yeah. I will get it to you, Arlene, and help you carry it to your car. Thank you all.
Thank you, Alberta. That was fun to have a special little treat at the end of our thing. I just also want to remind everybody with our committee meetings, like she said, healthcare, all of our committee meetings are open to all of our members. So please feel free to join in at any time with all the fun event planning and serious work that we do have ahead of us to do with the little fun. So thank you all and have a great holiday. Thank you. Thank you very much.